Good morning, friends. I think the first thing I would like to emphasize that whenever you are taking up a treatment for a patient for retreatment, you have to exercise caution. Do not treat if the patient is happy. There are multiple occasions when the patient comes with no complaints, but my optometrist writes down on the charts that he or she has a 0.75 residual. Maybe approaching presbyopic age group, but that might be actually good for them. So do not create a problem when none exists, and if you have a satisfied patient, best is to leave him or her alone. And again, whenever you are treated facing a patient with residual refractive error, you have to understand that iatrogenic ectasia is first manifests as a recurrence of power. Again, if there is early cataract which can occur in high myopic individuals, there could be lenticular myopia, which obviously should not be treated on the cornea. Retinal diseases, onset of presbyopia, etc. could cause a drop in visual acuity, and that should not be attributed to power. Again, before taking up a patient for retreatment, you have to ensure that the best corrected visual acuity is near normal, or at least what was there in the preoperative level, so that you know that it's the power which is at fault and you need to address that. So what are the prerequisites for me to take up a patient for retreatment? Usually I wait for at least a period of 6 months, because it could be either regression or a residual power. We need stable refraction, stable topography at an interval of at least three months, done twice over, and then examine previous refractive surgical details, especially if it has been done elsewhere. And again, I would like to leave behind, take up corneas only which have a pachymetry of more than 450 microns, and stick to the golden rule that leave behind a residual stomal bed of at least 300 microns. These are diseases that I treat very aggressively: dry eye, meibomian gland disease. Optimizing the ocular surface is most important. Sometimes it might be a very unhappy patient with a residual error of 0.5, 0.75 diopters, but once you optimize the ocular surface, the patient might be quite comfortable, it may not be the power which is causing the problem, but inappropriate ocular surface, and that needs to be optimized before you take up these patients for a retreatment. What are the two major choices available for us? Recutting a new flap is something that I did 20 years back, and at that time it used to leave behind small silvers of tissue that could cause irregular astigmatism, so that's not an option. Relift the original flap or surface ablation on the flap are the two things that I'm going to talk about. Relifting the flap, I used to pride myself with the fact we started doing Lasik way back in 1997, that even after 12-15 years I can lift back flaps. As you can see, this is something which is I'm lifting over after 12 years and then going ahead with the laser vision correction for the residual power and putting the flap back. It's hardly a 30-second procedure. And one thing you need to notice and understand is that whenever you're dealing with a femtosecond flap, it's a little more difficult to lift. These are two eyes, one treated with microkeratome 8 years back, femtolastic just 9 months back. It's not that the other one is being played slow, it's actually the difficulty I face while relifting this flap. And it's doable. Every femtosecond flap can also be lifted up, but then the edges heal up better, the interface heals up better, which in a way is a good thing. That's exactly what we want, and we don't want these flaps to be displaced too quickly. So why is it that we have another option? It's simply because you have the chance of epithelial ingrowth whenever that can happen after primary LASIK also, but the chances significantly increases whenever you do a relift. These epithelial ingrowth in our cases have been quite few and far, but then these are some of our own cases, and whenever it encroaches on the visual axis, it causes irregular astigmatism that needs to be addressed. And one of the major causes for epithelial ingrowth, the incidence is very highly variable. It has been reported anything between 2 to 43%. The later the flap lift is done, untidy epithelial edges, excessive maneuvering, older the age group of the patient, if the primary treatment has been done for hyperopic corrections, and if there are epithelial abnormalities, these are the instances when epithelial ingrowth chances are higher. Most importantly, relevant to this talk is this study, and this has also been substantiated by other studies, where it shows that within 3 years of primary LASIK, if you lift up the flap, then there is about 1% chance of epithelial ingrowth. But if you do it after 3 years, it increases by almost 7 times. It is an empirical number. Other studies may not have exactly the same statistics, but suffice it to say that the later you lift up the flap, more are the chances of this epithelial ingrowth. But of course, the good thing is that even if epithelial ingrowth occurs, we can always deal with it using mitomycin C and relifting it. And what about this other option that I was talking about, that's PRK over flap? Is fairly simple. What we do, whether it's a flap or a cap, we do the same thing. Even after a SMILE procedure, we do nearly the same thing, in the sense that we do a surface procedure, a PTK procedure, remove about 50 microns of tissue. Then whatever small islands are there, we wipe them away. And usually what you get, you do see a lot of striations on the residual bed, but that need not bother you. Go ahead and treat the residual power, which is usually small. Use mitomycin C. In these cases, I use 0.02% for a period of 1 minute, and subsequently place a contact lens. And of course, the discomfort is there, but now if you handle these patients optimally, I find that this is really not a problem. So what exactly are the disadvantages? As I just mentioned, obviously pain and discomfort for a couple of days, but then the safety that accrues with it is something that I would not compromise on. Slower visual recovery, haze which might be occurring but may not be a problem since we usually treat very small powers. But in case you go through the thickness of the flap or the cap and start treating the bed, the chance of the haze becomes significantly more. So you should be cognizant of that and make sure that you try to confine your treatment within the flap, and avoiding going through the flap, and prolonged medication. Usually we put these surface ablation treatment patients, whether it's primary treatment, secondary treatments for all low dose steroids, loteprednol for almost 4 months. And SMILE is something that many of us are doing in significant numbers. This is one option that is available to us, where it's a circle software. What we do is to extend the cap that has been created peripherally and the edges of the cap, and then you have a way to approach the depth of the underneath the cap and convert that into a flap. Basically, you lose the advantages of doing a SMILE, a flapless procedure, but then this works well. We have done 2 or 3 cases, but in our own experience, we find that doing a PRK procedure is equally effective, and because of the cost involved, we more often stick to that. And when, as has been alluded to by other speakers, whenever you are faced with a abnormal cornea, it's always a good idea to do the treatment as a topo-guided treatment on the surface of the cornea. Obviously, if you do it under a flap and then expect it to go ahead and manifest on the surface, that's something that does not always work. So as far as the treatment profile itself is concerned, if it's only pure refractive error, I go ahead with wavefront optimized. If large amounts of coma and trefoil is there, it's wavefront guided. If it's essentially irregular cornea, it's topo guided treatment that we do. And if whenever it's wavefront guided or topo guided, it's PRK, which is preferable. So in summary, there are 2 options that are available to us when it comes to enhancement. One is flap lift, another is laser on the bed. If it's essentially under treatment, I'm treating the patient within a year or 2, I'd go ahead and lift up the flap and treat, because that's somewhat more easier on the patient. But whenever it's beyond 2 to 3 years, doing it on the surface of the cap or the flap is a good idea. And that makes the treatment so much safer, reduces or makes the chance of epithelial growth almost nil. The last slide of mine, I was also asked to correct, what would you do to treat regression, myopic regression? This is one study. There are just a couple of other studies which show that when you put these patients about 0.5% timolol on a prolonged period of time, even after it's discontinued after 6 months, the regression tends to get arrested. Of course, this has to be borne out, but since it has little side effect, whenever you are faced with a problem of regression, you might try this out before resorting to retreatment. Thank you so much for your kind attention.